Welcome, future nurses. Today we turn our attention to one of the most time-sensitive and critical areas in nursing, the care of clients with cerebrovascular disorders. Conditions such as stroke and transient ischemic attacks are leading causes of disability and death worldwide, and rapid nursing assessment can mean the difference between recovery and lifelong impairment. In this session, we will explore the pathophysiology of ischemic and hemorrhagic strokes, identify high-priority signs and symptoms, and review evidence-based interventions that guide acute management and rehabilitation. We will also highlight NCLEX strategies to help you recognize warning signs quickly and prioritize interventions under pressure. By the end of this lecture, you will feel more confident in your ability to act swiftly and provide life-saving care for clients facing cerebrovascular emergencies. Hold on, there is something exciting for you all. I want to give you something that could completely change your preparation. If you're aiming to pass on your very next attempt, the Ultimate NCLEX Crash Course is your shortcut. Already trusted by more than 100,000 nursing students who cleared their exams successfully. What makes it different? It's an all-in-one package, designed to cover every part of your NCLEX prep, interactive live classes, and easy-to-watch recorded lectures, 5,000 exam-style practice questions, 30 complete practice tests, ebooks, and PDF notes for revision, a ready-to-use student planner, NGN questions broken down in detail during comprehensive lectures. This isn't just another review, it's everything you need in one place. Scan the QR code right now or use the link in the description to enroll instantly and grab free content, including PDF notes, practice tests, and NCLEX quizzes. You'll also get access to our Telegram and WhatsApp channels for even more free resources to keep you ahead. Let us smoothly move into this next clinical reasoning question that highlights the importance of recognizing subtle but critical neurologic changes in elderly clients. A nurse is making a home health visit to evaluate a 79-year-old client. During the assessment, the nurse notes a sudden change from the client's baseline neurologic functioning. The question we must answer is, which clinical finding is most suggestive that the client may be experiencing transient ischemic attacks, often called TIAs? Here are the options to consider. The first option is brief periods of unilateral weakness. The second option is brief periods of respiratory distress. The third option is brief periods of photosensitivity. And the fourth option is brief periods of stabbing head pain. The correct answer is option 1, brief periods of unilateral weakness. To understand why, let us examine the pathophysiology behind TIAs. A transient ischemic attack is essentially a temporary, mini stroke caused by reduced blood flow to a localized area of the brain. Symptoms typically resolve within minutes to hours and do not leave permanent deficits, but they serve as a warning shot that a major stroke may soon follow. In fact, 1/3 of clients who experience a TIA will progress to a stroke within 5 years, with the highest danger in the first 48 hours. Recognizing these warning signs is critical for prevention. Now let us break down the options one by one. Option 1, brief periods of unilateral weakness, is correct. TIAs often produce focal neurologic deficits that reflect the vascular territory involved. Clients may suddenly develop weakness, numbness, or paralysis affecting one side of the body, the face, or a limb. Other hallmark findings can include sudden temporary blindness in one eye, double vision, dizziness, slurred speech, or difficulty with coordination. Because these symptoms resolve quickly, they can be overlooked, but they should always be treated as emergencies. Moving to option 2, brief periods of respiratory distress, this is incorrect. Respiratory distress is not a classic manifestation of TIAs. Although brainstem strokes may impair respiratory drive, transient ischemic events usually do not. If sudden respiratory distress is present, the nurse should instead consider conditions such as pulmonary embolism, acute asthma, or decompensated heart failure. Looking at option 3, brief periods of photosensitivity, this is also incorrect. Sensitivity to light is more commonly associated with migraine headaches, meningitis, or eye disorders. TIAs can cause visual disturbances, but these are typically blurred vision, double vision, or temporary blindness in one eye. Light sensitivity alone is not an indicator of cerebral ischemia. Finally, option 4, brief periods of stabbing head pain, is incorrect as well. A sudden and severe headache, often described as the worst headache of my life, is more suggestive of subarachnoid hemorrhage or other intracranial bleeding. While some individuals with TIAS may experience vague headache, stabbing or severe pain is not a defining feature and should not be assumed to indicate a TIA without other focal neurologic signs. Here is the clinical pearl to take forward. TIAS should always be seen as medical emergencies. Think of them as the brain's warning signals that a stroke is on the horizon. Nurses play a vital role by recognizing early signs and ensuring immediate referral for diagnostic workup and preventive measures. Risk factor modification, such as controlling hypertension, diabetes, or atrial fibrillation, alongside preventive therapies like antiplatelets, anticoagulants, or statins, can significantly reduce the chance of a full-blown cerebrovascular accident. Stancoast. Pearl. TIAS are the body's warning shots. Brief reversible neurologic deficits today can mean a major stroke tomorrow. Let us continue with the next clinical reasoning scenario, which challenges your ability to prioritize immediate nursing actions in the face of subtle but high-risk neurological symptoms. A 68-year-old client reports experiencing sudden episodes of slurred speech and transient weakness in the right arm, each lasting less than 20 minutes and resolving on their own. After gathering more data about the client's symptoms, the critical question is, which nursing action should be taken next? Here are the available options to consider. The first option is to explain the event in understandable language. The second option is to refer the client for immediate medical evaluation. The third option is to recommend taking a low-dose aspirin once daily. The fourth option is to advise the client to call 911 if symptoms persist. The correct answer is option 2. Refer the client for immediate medical evaluation. Now let us carefully analyze the reasoning. A transient ischemic attack, often referred to as a TIA, represents a temporary interruption of blood flow to a part of the brain, causing neurologic dysfunction without leaving permanent damage. Although the symptoms resolve spontaneously, the clinical significance is profound. Research shows that approximately 1/3 of individuals who experience a TIA will later develop a stroke, with the highest risk occurring within the first 24 to 48 hours. Because of this, every TIA must be treated as a medical emergency requiring immediate diagnostic evaluation. Standard assessments include CT or MRI of the brain, carotid imaging, electrocardiogram or echocardiogram to rule out atrial fibrillation, and a series of laboratory studies. The goal is to rapidly identify and treat the underlying etiology, whether it be a cardiac source of emboli, carotid artery stenosis, or uncontrolled hypertension. Looking at the options, the first choice, explaining the event in understandable language, is incorrect. While client teaching is always valuable, simple explanation without urgent referral does nothing to prevent a potential stroke. Education is supportive, but it cannot replace timely evaluation and intervention. The second choice, referring the client for immediate medical evaluation, is correct. This action ensures that the client is quickly assessed in an emergency or specialized stroke center setting, where interventions such as antiplatelet therapy, anticoagulation for atrial fibrillation, or carotid endarterectomy can be initiated to significantly reduce future stroke risk. The third choice, recommending low-dose aspirin daily, is also inappropriate at this stage. While aspirin is indeed used as part of secondary stroke prevention, it cannot substitute for a full diagnostic workup. Giving aspirin alone may delay more specific interventions and provide a false sense of security. Finally, the fourth choice, advising the client to call 911 if symptoms persist, is dangerous because it suggests waiting for symptoms to become continuous or worsen before seeking help. By that time, permanent neurological damage may already have occurred. Immediate evaluation is essential even if symptoms resolve completely. Here is the Stancoast pearl for this concept. TIAs are the brain's fire alarm. They may stop ringing quickly, but they are warning of an impending blaze. The highest stroke risk occurs within 48 hours of a TIA, so never delay referral. Essential evaluation includes brain imaging, carotid studies, cardiac workup, and labs. Preventive strategies involve antiplatelet therapy, anticoagulation when atrial fibrillation is present, carotid revascularization for significant stenosis, and aggressive control of modifiable risk factors like hypertension, diabetes, high cholesterol, and smoking. All right, let us move on to this important NCLEX-style scenario that highlights neurological assessment skills. Later in the day, the client is admitted to the hospital after emergency medical personnel respond to a call that the client has been found unconscious. The physician orders frequent neurologic checks, and now the nurse in the emergency department must assess the client's neurologic function. The question is, when checking the client's pupils, which technique is correct? Here are the options to consider. The first option is to shine the pen light from the side of the temple into each pupil. The second option is to cover one of the client's eyes, then the other eye. The third option is to brighten the lights in the examination area. And the fourth option is to observe for extraocular eye movement. The correct answer is option 1, which is to shine the pen light from the side of the temple into each pupil. Now, let us break this down step by step so you understand the reasoning clearly. Pupillary assessment is a cornerstone of neurologic checks in any client with an altered level of consciousness. Pupil size, equality, and reaction are among the most sensitive indicators of increased intracranial pressure, herniation, or compression of cranial nerve 3. Therefore, accuracy of technique is essential. Option 1 is correct because introducing the light beam laterally from the side of the temple prevents the client's pupils from constricting prematurely due to direct anticipation of the light. The nurse can then observe the direct response, which is constriction of the illuminated pupil, and the consensual response, which is constriction of the opposite pupil. Even if the client is unconscious and cannot follow instructions such as look into the distance, this lateral approach remains the best method. Normal findings are equal, round pupils that constrict briskly and symmetrically, making this the gold standard for neurologic checks. Shifting to option 2, which is to cover one eye and then the other, we can see why this is not correct. That method is actually used in ophthalmology to assess ocular dominance or visual field defects, not pupillary reactivity. In a neurologically unstable or unconscious client, wasting time with a cover test is irrelevant and may delay urgent findings. Moving to option 3, which suggests brightening the lights in the examination area. This too is incorrect because ambient bright light causes diffuse constriction of both pupils, masking subtle abnormalities. For the most accurate results, the environment should be dim, allowing the focused pen light beam to highlight true differences in pupil reaction. Finally, option 4, which is observing for extraocular movements, is also incorrect in this context. Extraocular movement testing evaluates cranial nerves 3, 4, and 6, but it requires client cooperation. In an unconscious client, this cannot be performed voluntarily, and more importantly, it does not address the physician's order for frequent pupillary checks. To summarize with some high-yield pearls for NCLEX preparation, always dim the environment before assessing pupils. Always use a lateral approach with the pen light to avoid triggering accommodation reflex. And remember the acronym PERRLA, pupils equal, round, reactive to light, and accommodation. Unequal, fixed, or dilated pupils can be the earliest sign of impending herniation, requiring immediate action. And here is your Stancoast. Pearl. Pupils are the window to the brain. Even the smallest change in reactivity may be the very first warning sign of rising intracranial pressure. Moving into another critical scenario, imagine a physician has ordered a computed tomography scan of the brain with intravenous contrast for a client admitted with sudden confusion and severe headache. Before the procedure, the nurse explains the purpose of the scan to the client and spouse, then carefully asks about allergy history. The spouse mentions that the client has several allergies, and the question is, which allergy must the nurse immediately report to the physician before allowing the procedure to proceed? The options are option 1, penicillin, option 2, shellfish, option 3, latex, and option 4, metal. The correct answer is option 2, shellfish. Now let us break this down in detail. A CT scan with contrast is often ordered to detect hemorrhage, tumors, ischemia, or other intracranial abnormalities. The contrast dye usually contains iodine, which makes the vascular and soft tissue structures more visible. However, iodine sensitivity is a known trigger for dangerous hypersensitivity reactions. That is why a reported shellfish allergy is highly significant. It commonly indicates cross-sensitivity to iodine. This places the client at risk for mild to severe reactions, including urticaria, bronchospasm, or even life-threatening anaphylaxis. The nurse must report this finding immediately so the physician can decide whether to premedicate with corticosteroids and antihistamines or to consider a non-contrast CT or an alternative test such as magnetic resonance imaging. Looking at the other options helps reinforce the reasoning. A penicillin allergy, while important for antibiotic planning, does not affect contrast dye safety, and therefore is not an immediate contraindication. A latex allergy, although serious in operative or procedural environments where latex gloves and catheters are used, does not directly impact CT contrast administration. Finally, a metal allergy may be relevant for clients undergoing MRI, where metallic implants or fragments can pose serious risks, but it has no impact on CT scan contrast use. From a nursing perspective, the implications are very clear. Always assess allergies thoroughly before contrast studies, report iodine or shellfish allergies without delay, and monitor for nephrotoxicity in clients with kidney impairment. Be prepared with emergency medications like epinephrine and antihistamines in case of a hypersensitivity reaction. And always educate both the client and family so they understand the risks and the importance of allergy disclosure. Here is the golden takeaway. Stancoast. Pearl. Shellfish allergy equals iodine sensitivity. Always think contrast reaction first. When in doubt, report before injecting. Let us now transition into a scenario that highlights one of the most essential ethical and legal principles nurses must follow. A client has been admitted to the medical unit after a stroke. During visiting hours, a member of the client's church approaches the nurse and asks, "Just how bad is the stroke?" The nurse, guided by the Health Insurance Portability and Accountability Act, or HIPAA, appropriately avoids disclosing any details about the client's medical condition. This brings us to the important question. Based on HIPAA regulations, which of the following types of client information are also considered protected health information, or PHI, and therefore must not be disclosed without proper authorization? Here are the options. Option 1 is the client's date of birth. Option 2 is the client's social security number. Option 3 is the client's insurance information. Option 4 is the client's address. Option 5 is the client's occupation. And option 6 is the client's computer passwords. The correct answers are options 1, 2, 3, and 4. The client's date of birth, social security number, insurance information, and address. Now, let us break down the reasoning in detail. Starting with option 1, the client's date of birth. This is correct because birth dates are considered PHI. They serve as unique identifiers that, when combined with medical information, can easily trace back to a patient's identity. For instance, linking a date of birth with a specific diagnosis could reveal exactly who the information belongs to. Moving to option 2, the social security number. This is also correct and is one of the most sensitive forms of PHI. If disclosed, it could lead to identity theft, financial fraud, or misuse of health benefits. HIPAA specifically lists social security numbers as protected identifiers that must always remain confidential. Next, option 3, the client's insurance information, is again correct. Insurance policy numbers, billing details, and coverage documents are considered PHI because their disclosure can expose a patient to fraud or privacy violations regarding their treatment and financial responsibilities. Nurses are legally obligated to safeguard this information at all times. Looking at option 4, the client's address, this is another correct answer. Geographic identifiers such as home address, phone number, or even a full zip code are classified as PHI because they can link back to the patient's identity. HIPAA requires strict protection of such information, just like it does for medical records. Turning to option 5, the client's occupation, this is incorrect. While occupation is indeed personal, HIPAA does not automatically classify it as PHI unless it is directly tied to health data in a way that identifies the patient. On its own, it is not considered protected under HIPAA. Finally, option 6, the client's computer passwords, is also incorrect. Although passwords are crucial for cybersecurity and access to electronic records, they are not defined as PHI under HIPAA. Instead, they fall under organizational IT security policies rather than federal patient privacy laws. The key clinical takeaway is this. HIPAA safeguards identifiable health information, which includes demographic details like date of birth and address, unique identifiers such as social security numbers, and financial data like insurance records. Nurses must never disclose such information unless the patient has provided explicit authorization. Stancoast Pearl. And here is your NCLEX memory tip. Always ask yourself, can this piece of information identify the patient if combined with health data? If the answer is yes, it qualifies as PHI and must be protected under HIPAA. Let us smoothly move into this next high-yield question that tests your knowledge of neurologic assessment in stroke care. A nurse is monitoring a client admitted with an acute ischemic stroke, and during the shift assessment, the nurse carefully evaluates for changes that may indicate rising intracranial pressure. Which clinical finding would be the strongest indicator of increasing intracranial pressure that requires immediate intervention? Here are the options for consideration. The first option is that systolic blood pressure increases and diastolic pressure decreases. The second option is that systolic blood pressure decreases and diastolic pressure increases. The third option is that the apical heart rate is greater than the radial rate. The fourth option is that the radial pulse rate is greater than the apical rate. The correct answer is option 1, systolic blood pressure increases and diastolic pressure decreases. Now, let me explain why this is correct. When the systolic blood pressure rises while diastolic blood pressure falls, the result is a widened pulse pressure, which is a hallmark feature of increased intracranial pressure. This finding is part of Cushing's triad, a classic but late neurologic sign consisting of widened pulse pressure, bradycardia, and irregular respirations. The mechanism involves increased intracranial pressure compressing the brainstem, especially the medulla, which controls cardiovascular and respiratory regulation. A pulse pressure that widens beyond 50 millimeters of mercury reflects the body's attempt to preserve cerebral perfusion in the face of rising intracranial pressure. Without immediate recognition and intervention, this progression can lead to herniation and death. Therefore, nurses must be alert to even early trends in widening pulse pressure and report them promptly. Shifting to the second option, this one is incorrect because a drop in systolic pressure with a rise in diastolic pressure narrows the pulse pressure, which is typically associated with hypovolemic shock, cardiac tamponade, or advanced heart failure, but not with increased intracranial pressure. This represents a cardiovascular compromise rather than a neurologic emergency. Moving on to the third option, this is also incorrect because an apical heart rate greater than the radial rate represents a pulse deficit. This typically occurs with arrhythmias, such as atrial fibrillation or premature ventricular contractions. While important for cardiac care, it is unrelated to intracranial pressure changes. Finally, the fourth option is incorrect because it is physiologically impossible for the radial pulse to exceed the apical pulse. This choice is included as a distractor to ensure the test taker recognizes its logical inconsistency. In reality, the radial rate may be less than the apical in cases of conduction defects, but never greater. To close this explanation with a clinical pearl, always think of Cushing's triad when suspecting increased intracranial pressure. The three hallmarks are widened pulse pressure, bradycardia, and irregular respirations. These are late and dangerous signs, often occurring just before brain herniation. Nurses must act immediately by elevating the head of the bed, administering osmotic or hypertonic agents such as mannitol or hypertonic saline, and notifying the provider without delay. Quick recognition and intervention can save a client's life in this critical neurologic emergency. Let us now transition into another high-yield NCLEX practice scenario that will challenge your understanding of airway management in neurologic clients. The charge nurse documents the nursing diagnosis, risk for ineffective airway clearance related to inability to swallow, on the care plan of a client with acute neurologic impairment. While implementing safety measures, the nurse must determine which intervention best addresses the priority nursing diagnosis. Which action is most appropriate to include? Here are the options. Option 1 is to keep the client supine. Option 2 is to remove all head pillows. Option 3 is to perform oral suctioning. Option 4 is to provide frequent oral hygiene. The correct answer is option 3, perform oral suctioning. The reasoning here is straightforward yet critical. The priority intervention for a client who cannot swallow and is at risk for ineffective airway clearance is to maintain a patent airway. When a client cannot effectively clear secretions, oral suctioning is required to prevent obstruction, aspiration, or hypoxemia. Suctioning directly removes mucus, saliva, or vomitus that could occlude the airway and compromise oxygenation. This intervention aligns perfectly with the ABCs of prioritization: airway, breathing, circulation, where airway always takes precedence. In neurologic conditions such as stroke, traumatic brain injury, or advanced Parkinson's disease, impaired gag and swallow reflexes make suctioning not only appropriate, but often life-saving. Looking at the first incorrect option, keeping the client supine actually increases the risk of aspiration because secretions tend to pool in the posterior pharynx. It also restricts diaphragmatic movement, making ventilation less effective. Evidence-based care supports side-lying or semi-Fowler's positioning instead, so supine is contraindicated. Moving on to the second option, simply removing all head pillows does not significantly contribute to airway clearance. While positioning is important, removing pillows alone does not prevent secretion buildup or aspiration. Optimal practice is maintaining the head slightly elevated or turned to the side. As for the fourth option, providing frequent oral hygiene is indeed beneficial for infection prevention, comfort, and reducing ventilator-associated pneumonia risk, but it does not directly address airway clearance. It is a supportive intervention, not a primary airway-saving action. Here is your Stan Coast Pearl. When caring for any client with impaired swallowing or gag reflex, always prioritize suctioning and safe positioning first. Oral care supports long-term airway health, but will not save a life in the immediate moment. An obstructed airway can lead to death within minutes, while poor oral hygiene only harms over days. Always remember that in nursing, airway is the #1 priority. Let us now move forward with another high-yield NCLEX practice question that emphasizes safety and client assessment. A client has experienced a cerebrovascular accident, commonly called a stroke, and is diagnosed with right-sided hemiplegia. During the admission assessment, the nurse determines that this client is at risk for falls. Considering universal fall precautions and client-specific factors, which conditions would significantly increase any client's risk for falls? This is a select all that apply question, so listen carefully. Here are the options. The first option is that the client is male. The second option is that the client is taking antibiotics. The third option is that the client is confused. The fourth option is that the client has vertigo. The fifth option is that the client has impaired vision. And finally, the sixth option is that the client needs help with toileting. The correct answers are options 1, 3, 4, 5, and 6. Now, let me walk you through the reasoning. Starting with option 1, the client is male. This is correct because although being male is not a physiologic risk factor, research shows that men are more likely to overestimate their physical, avoid asking for help, or engage in risk-taking behavior. When combined with stroke-related mobility issues, this makes being male a recognized psychosocial risk factor for falls. Looking at option 2, the client is taking antibiotics. This is incorrect. Antibiotics, as a drug class, are not directly linked to fall risk. Only if they cause secondary effects such as dizziness, diarrhea, or hypotension would they contribute. Unlike sedatives, antihypertensives, or opioids, antibiotics are not included in the Joint Commission's high-risk medication list for falls. Now turning to option 3, the client is confused. This is correct because confusion, disorientation, or delirium dramatically increases fall risk. A confused client may not follow safety instructions, may misjudge their limitations, or may attempt to ambulate without help. Cognitive impairment is consistently one of the strongest predictors of inpatient falls. Moving on to option 4, the client has vertigo. This is correct as vertigo directly disrupts balance and equilibrium, resulting in unstable gait and potential sudden collapse. Clients with vestibular dysfunction or stroke-related dizziness need strict fall precautions, including bed alarms, supervision, and assistance when ambulating. Next is option 5, the client has impaired vision. This is correct because vision deficits prevent clients from recognizing hazards in their environment. After a stroke, hemianopsia or decreased acuity can make navigation unsafe, leading to tripping or bumping into obstacles. The Joint Commission identifies sensory deficits such as poor vision as critical intrinsic fall risks. Finally, option 6, the client needs help with toileting. This is correct because altered elimination patterns, including urgency or incontinence, are one of the leading causes of inpatient falls. Many clients try to rush unassisted to the toilet, especially at night, increasing their fall risk. Strategies such as bedside commodes, scheduled toileting, and staff assistance are vital prevention measures. Here is the clinical insight. Fall prevention is a national patient safety goal mandated by the Joint Commission. Risk assessment is required at admission, during hospitalization, and whenever a client's condition changes. Nurses often use tools like the Morse Fall Scale, or the Hendrich 2 fall risk model, to identify risks and implement interventions such as non-skid footwear, frequent rounding, toileting schedules, and family education. And here comes your Stancoast Pearl. Always think of the 3 C's and 3 S's: cognition, continence, comorbidities, and sensory deficits. Sedating medications, stability issues. If 2 or more are present, that client is automatically high risk and needs enhanced fall prevention interventions. Moving forward with another high-yield NCLEX practice scenario, let us consider a client who has recently experienced a cerebrovascular accident, also known as a stroke, and is now living with right-sided hemiplegia. During medication review, the nurse realizes that this client has been assessed as being at high risk for falls. The question we must answer is, which classifications of medications would most significantly contribute to fall risk in this type of client? This is a select all that apply question, so let us carefully analyze each option. The possible answers include antihyperlipidemics, benzodiazepines, sedatives or hypnotics, opioids, anticonvulsants, and antihypertensives. The correct selections here are options 2, 3, 4, 5, and 6. Now let us work through the reasoning step by step. Beginning with option 1, antihyperlipidemics. This choice is incorrect. Medications such as statins or fibrates are primarily used to lower cholesterol and reduce cardiovascular risk. While they may cause rare adverse effects such as myopathy or liver dysfunction, they do not typically impair balance, alertness, or blood pressure regulation. Therefore, they are not considered major contributors to falls. Shifting to option 2, benzodiazepines, this is correct. Drugs like diazepam, lorazepam, or alprazolam act by enhancing the effect of gamma-aminobutyric acid in the brain, producing sedation, muscle relaxation, and anxiolysis. In stroke survivors who already have impaired motor function, these medications can worsen confusion, slow reflexes, and cause unsteady gait. As a result, the likelihood of falls dramatically increases, especially if the client attempts to ambulate without assistance. Looking at option 3, sedatives and hypnotics, this is also correct. These agents, including zolpidem or triazolam, are designed to induce sleep but often cause next-day drowsiness, dizziness, and grogginess. When combined with stroke-related weakness or impaired mobility, sedatives place clients at a very high risk for nighttime falls, especially during trips to the bathroom. Turning our attention to option 4, opioids, this too is correct. Medications like morphine or oxycodone are effective for pain, but bring along side effects such as drowsiness, dizziness, and orthostatic hypotension. They may also blunt protective reflexes and impair judgment. For a client with neurologic deficits, opioids compound the danger of falls and can lead to serious complications like fractures or head injuries. Next is option 5, anticonvulsants, which is another correct choice. Commonly prescribed to prevent seizures, drugs such as phenytoin or carbamazepine also depress the central nervous system. Side effects like dizziness, blurred vision, and ataxia interfere with balance and coordination. In someone already weakened by a stroke, these risks are magnified, making falls a frequent adverse outcome. Finally, option 6, antihypertensives, must also be included. Whether beta blockers, calcium channel blockers, or diuretics, these drugs reduce blood pressure, but sometimes too much. Orthostatic hypotension, dizziness, and syncope can result, leaving stroke survivors vulnerable to sudden unsteadiness when rising from bed or standing. From a clinical perspective, the key takeaway is that polypharmacy amplifies the danger. When sedatives, anticonvulsants, opioids, and antihypertensives are given together, their combined effects create an even higher fall risk. Older adults are especially vulnerable because they metabolize drugs more slowly, intensifying side effects like sedation or hypotension. Nurses must therefore conduct thorough medication reconciliation, assess for central nervous system depression, monitor for postural blood pressure changes, and implement fall prevention measures such as bed alarms, non-slip footwear, and supervised ambulation. Client education plays a vital role as well. Families should be taught to report dizziness, encourage the client to avoid sudden position changes, and always provide assistance with ambulation. And here comes the Stancoast Pearl. Never think of falls as just a neurologic problem. Stroke itself causes weakness, but it is the combination of sedating drugs, centrally acting anticonvulsants, opioids, and blood pressure-lowering agents that create the perfect storm for falls. antihyperlipidemics, while crucial for vascular health, rarely contribute to acute fall risk. Let us now move into another crucial NCLEX practice scenario that highlights the nurse's role in client safety. The question asks, a nurse is caring for a hospitalized client who has been identified as high risk for falls based on standardized assessment tools. Considering both immediate safety priorities and evidence-based best practices, which interventions should the nurse implement to reduce fall risk? This is a select all that apply question. So let us review the possible interventions carefully. The available options are: instruct the client to ask for help before getting up, turn on the bed alarm, apply restraints to the upper extremities, advise the client's family to inform the staff when leaving, place the bed in the lowest position, and obtain an order for a physical therapy consult. The correct answers here are options 1, 2, 4, and 5. Beginning with option 1, instruct the client to ask for help before getting up. This is correct. Educating the client is one of the most effective frontline strategies to reduce fall risk. Many high-risk clients may underestimate their physical limitations or forget their restrictions, so teaching them to call for assistance before attempting mobility ensures staff can supervise and support them. This aligns with the Joint Commission's patient safety goals that emphasize education as a key fall prevention measure. Next, option 2, turning on the bed alarm, is also correct. Bed alarms provide an immediate safeguard by alerting staff when the client attempts to get up without help. This is particularly important for clients who are confused, sedated, or impulsive. Bed alarms are considered evidence-based, non-invasive tools that balance client safety while preserving dignity, unlike restraints. Looking at option 3, applying restraints to the upper extremities, this choice is incorrect. Restraints are not appropriate as a first-line fall prevention method. In fact, they are linked with serious complications such as increased agitation, immobility, impaired circulation, and even a higher risk of falls if the client attempts to escape. Both the American Nurses Association and the Centers for Medicare and Medicaid Services recommend that restraints should only be used as a very last resort, and with a physician's order, when all other options have failed. Now, considering option 4, advising the client's family to inform the staff when leaving, this is correct. Family members often act as informal supervisors at the bedside, and if they leave without notifying staff, the client may be left unattended during a vulnerable moment. Encouraging family-staff communication strengthens collaboration and ensures continuous monitoring of the client's safety. Moving on to option 5, placing the bed in the lowest position, this is correct as well. Adjusting the environment is a simple but powerful strategy. Lowering the bed reduces the severity of injury should a fall occur and supports safer transfers. Hospital fall prevention bundles consistently include this intervention because it addresses safety at the environmental level. Finally, option 6, obtaining an order for a physical therapy consult, is not part of the immediate interventions. While physical therapy is important for strengthening and gait training, it does not address the urgent short-term fall risk during an acute hospitalization. It plays a valuable role in long-term mobility improvement, but it does not substitute for immediate bedside precautions such as alarms, bed positioning, and family communication. Stancoast. Pearl. Fall prevention is always multimodal. No single intervention is sufficient. A true safety net is created by combining client education, bed alarms, environmental adjustments, and family collaboration. Restraints are avoided unless absolutely necessary, and physical therapy contributes to long-term mobility but not to urgent fall prevention needs. Hold on, there is something exciting for you. All I want to give you, something that could completely change your preparation. If you're aiming to pass on your very next attempt, the Ultimate NCLEX Crash Course is your shortcut. Already trusted by more than 100,000 nursing students who cleared their exams successfully. What makes it different? It's an all-in-one package, designed to cover every part of your NCLEX prep. Interactive live classes and easy-to-watch recorded lectures. 5,000 exam style. Practice questions. 30 complete practice tests, ebooks, and PDF notes for revision. A ready-to-use student planner. NGN questions broken down in detail during comprehensive lectures. This isn't just another review, it's everything you need in one place. Scan the QR code right now or use the link in the description to enroll instantly and grab free content, including PDF notes, practice tests, and NCLEX quizzes. You'll also get access to our Telegram, and WhatsApp channels for even more free resources to keep you ahead. Now, shifting our attention to client mobility and safety, here comes an important NCLEX question. A nurse is preparing to transfer a client with left-sided hemiplegia from the bed to a wheelchair for the very first time after stabilization. The question asks, which nursing action demonstrates the safest and most evidence-based approach? Here are the options to consider. Option 1, instruct the client about how to balance with a walker. Option 2, position the wheelchair perpendicular to the bed. Option 3, ask the client if a gait belt is preferred. And Option 4, brace the paralyzed foot and knee during the transfer. The correct answer is Option 4, brace the paralyzed foot and knee during the transfer. Here is the reasoning behind this. Clients with hemiplegia have little or no voluntary motor control on the affected side, meaning the knee can buckle suddenly and balance is lost. By bracing the paralyzed foot and knee with the nurse's leg and body, stability is created, proper alignment is maintained, and the client can safely bear weight through the stronger side. This gold standard rehabilitation technique not only prevents injury, but also boosts the client's confidence during the transfer. Now, let us look at why the other options do not work. Option 1, instructing the client to balance with a walker is unsafe, because a walker requires strength and coordination from both arms. Since the paralyzed arm cannot contribute, attempting this too early only raises fall risk. Option 2, placing the wheelchair perpendicular to the bed, is also incorrect, because it forces the client into a wide turning angle. Best practice is to keep the wheelchair parallel to the bed, on the stronger side, so the transfer path is shorter, smoother, and safer. Option 3, asking the client if a gait belt is preferred, is inappropriate because the use of a gait belt is not optional when safety is at stake. Nurses must apply it whenever indicated, since it provides critical control in case of sudden imbalance. From a clinical perspective, the safest method involves placing the wheelchair parallel to the bed on the strong side, locking the brakes, removing the footrests, securing a gait belt, and bracing the weak knee with the nurse's leg. And here's the Stenosis pearl. When transferring a hemiplegic client, always work from the stronger side, stabilize the weaker leg, and use a gait belt without exception. Remember, wheelchair parallel, brakes locked, and footrests removed. These small steps make the difference between a safe transfer and a preventable fall. Let us now move into a question that highlights caregiver education, which is vital in the rehabilitation process. A client with right-sided hemiplegia is beginning a rehabilitation program after a recent cerebrovascular accident. The nurse is teaching the client's spouse how to correctly perform passive range of motion exercises to maintain joint mobility and prevent complications. The question asks, which instructions should the nurse include? Select all that apply. Here are the options to consider. Option 1, move the paralyzed limbs in as many directions as possible. Option 2, perform the exercises every 3 hours while the client is awake. Option 3, repeat each exercise 3 times for each joint. Option 4, take the client's pulse before beginning the exercises. Option 5, allow rest periods between exercises to prevent fatigue. And Option 6, begin the exercises systematically, working from head to toe. The correct answers are Options 1, 3, 5, and 6. Here is the reasoning. Option 1, move the paralyzed limbs in as many directions as possible, is correct because passive range of motion should be carried out in every plane the joint naturally moves, including flexion, extension, abduction, and rotation. This practice prevents contractures, maintains ligament elasticity, and promotes circulation, provided the movements are gentle and never forced. Moving on to Option 2, perform the exercises every 3 hours while the client is awake. This is incorrect. Such frequency is excessive and can cause unnecessary fatigue. Evidence-based practice recommends passive range of motion 2 to 3 times per day, not every 3 hours. Next, Option 3, repeat each exercise 3 times for each joint, is correct because 3 repetitions are the standard for maintaining flexibility and preventing stiffness while avoiding overexertion. Considering Option 4, take the client's pulse before beginning the exercises. This is incorrect because checking vital signs is not necessary unless there is a cardiovascular concern. Instead, caregivers should watch for signs of intolerance such as pain, shortness of breath, or color changes. Now looking at Option 5, allow rest periods between exercises to prevent fatigue. This is correct since clients with hemiplegia fatigue quickly, and short rest breaks enhance tolerance, prevent spasms, and support overall effectiveness of the therapy. Finally, option 6, begin the exercises systematically, working from head to toe, is also correct. A head-to-toe sequence ensures that no joints are skipped, creates a structured routine, and aligns with how full-body assessments are performed in clinical care. From a clinical perspective, clients with hemiplegia are at risk for contractures, muscle atrophy, venous stasis, and pressure injuries, making passive range of motion a cornerstone in their care plan. Educating the spouse also helps prevent caregiver strain and ensures consistency in therapy. Integrating proper positioning with splints, pillows, or trochanter rolls further supports recovery and alignment. And here's the Stand Coast Pearl to remember. System plus safety equals success. Always guide caregivers to follow a systematic head-to-toe approach. Move all joints gently. Repeat each motion 3 times, and build in rest breaks. This method not only protects the client from complications, but also safeguards the caregiver from strain, ensuring rehabilitation is safe and effective. Let us smoothly move into the next NCLEX-style scenario by exploring the use of a footboard, which is a vital part of nursing care for clients with prolonged immobility. The question asks, a nurse attaches a footboard to the bed of a client who is immobilized due to prolonged illness. Which statement best describes the correct positioning of the client's feet when using the footboard? Here are the options to consider. Option 1 states that the soles are perpendicular to the board. Option 2 states that the soles are parallel to the board. Option 3 suggests that the knees are flexed less than 90 degrees. And option 4 proposes that the ankles are extended more than 90 degrees. The correct answer here is option 2. The soles are parallel to the board. This is correct because the main purpose of a footboard is to maintain the feet in a functional position that mirrors normal standing alignment. In a natural standing posture, the soles of the feet are flat on the ground, with the ankles at 90 degrees and toes pointing upward. By ensuring the soles remain parallel to the board, the nurse prevents plantar flexion contractures, better known as foot drop. Foot drop occurs when dorsiflexor muscles weaken from immobility, causing the foot to fall into plantar flexion. This complication not only impairs mobility and gait, but also increases risks of pain, skin breakdown, and long-term disability. Thus, maintaining parallel alignment preserves biomechanics, enhances comfort, and makes eventual ambulation smoother. Now, let us analyze why the other options are incorrect. Starting with option 1, soles perpendicular to the board would force the toes directly against the board, placing the ankles into unnatural hyperflexion or twisting. This positioning increases pressure points, reduces circulation, and can cause Achilles tendon strain, making it both unsafe and non-functional. Moving to option 3, knees flexed less than 90 degrees might seem helpful for posture, but the footboard's purpose is not about knee position. It specifically prevents ankle contractures. Prolonged knee flexion, in fact, leads to stiffness, venous stasis, and even deep vein thrombosis, which are harmful outcomes. Finally, option 4, ankles extended more than 90 degrees, directly encourages plantar flexion, which is exactly the complication the footboard is designed to prevent. When ankles are left in this extended position, calf muscles shorten and stiffen, making dorsiflexion difficult or even impossible later. This interferes with walking, balance, and overall independence in daily living. From a broader clinical perspective, footboards serve as preventive interventions for bedbound clients, especially those with neurologic conditions, orthopedic trauma, or long-term mechanical ventilation. Immobilization commonly leads to muscle atrophy, joint contractures, impaired circulation, venous pooling, and neuropathic complications. By keeping the feet parallel, nurses protect musculoskeletal health, reduce complications, and make rehabilitation easier. Here is a simple Stand Coast Pearl to remember. Foot flat, future intact. Always keep the soles flat and parallel to the footboard at 90 degrees. This straightforward intervention safeguards against foot drop, supports long-term mobility, and preserves the client's independence. Let us now explore a high-yield NCLEX scenario that focuses on post-stroke communication support. A nurse is caring for a client who has recently experienced a left middle cerebral artery stroke, and the speech therapist reports that this client has developed expressive aphasia. The question asks, which nursing intervention is the most effective way to support communication with this client? Here are the options for consideration. Option 1 suggests speaking using a low tone of voice. Option 2 proposes providing a communication board and encouraging the client to point to printed words or phrases. Option 3 recommends assisting the client by completing their sentences when they struggle. And Option 4 encourages the client to repetitively practice verbalizing key words. The correct answer is Option 2. Provide a communication board and encourage the client to point to printed words or phrases. This is the best intervention because expressive aphasia, also known as Broca's aphasia, occurs when a stroke damages the dominant frontal lobe, specifically Broca's area. Clients in this situation can understand what is being said, but have great difficulty producing words fluently due to impaired motor planning of speech. By introducing a communication board, picture cards, or printed key phrases, the nurse offers a functional alternative pathway for the client to express needs effectively. This intervention helps preserve independence, decreases frustration, and respects the client's intact comprehension. It also reflects evidence-based practice in stroke rehabilitation, where compensatory strategies are emphasized until formal speech therapy shows improvement. Looking at why the other options are less appropriate, let us start with Option 1, which recommends speaking in a low tone of voice. This is incorrect because expressive aphasia does not involve hearing deficits. Lowering tone will not improve communication since the challenge lies in producing speech, not in hearing or understanding language. Clear, simple, and respectful communication is always good practice, but tone adjustments do not address the underlying neurologic impairment. Turning to Option 3, completing the client's sentences when they struggle, we find that this is not therapeutic. Although well-intended, finishing the client's thoughts deprives them of control, increases dependency, and may create further frustration. These clients need patience and time to communicate at their own pace, and interrupting them reduces opportunities for active participation in recovery. Finally, Option 4, encouraging verbal practice of key words, is also incorrect. Expressive aphasia is not caused by lack of practice or effort. It is a neurologic impairment. Forcing repetitive attempts may overwhelm and frustrate the client, leading to withdrawal from communication attempts. While structured exercises belong in the scope of speech therapy, the nursing role should emphasize functional, compensatory strategies that support day-to-day communication. Here is your Stand Coast Pearl to lock in this concept. Expressive aphasia means understand but cannot speak. Receptive aphasia means can speak but cannot understand. For NCLEX, always remember that the most therapeutic intervention is one that preserves dignity, reduces frustration, and promotes independence. Communication boards, writing tools, and adequate response time are your best strategies when caring for these clients. Let us move into this next advanced NCLEX practice question with a focus on stroke rehabilitation. A nurse is developing a rehabilitation plan of care for a client recovering from an acute ischemic stroke. During the early phase of rehabilitation, which nursing goal should be considered the highest priority to maximize long-term functional recovery? Here are the options to consider. The first option is to regulate bowel and bladder elimination. The second option is to prevent contractures and joint deformities. The third option is to address problems related to altered body image. And the fourth option is to foster positive coping strategies for depression. The correct answer is Option 2, to prevent contractures and joint deformities. Now, let us carefully walk through the rationale. Preventing contractures is the most critical goal because musculoskeletal preservation forms the foundation of stroke rehabilitation. Clients who experience hemiplegia, hemiparesis, or spasticity are at high risk for muscle shortening, joint stiffness, and irreversible immobility. If these complications develop, independence is permanently lost, regardless of whether emotional or elimination concerns are managed. Early interventions such as proper functional positioning, splinting, passive and active range of motion exercises, and collaboration with physical and occupational therapy are essential. Research clearly shows that preserving musculoskeletal integrity early leads to improved performance in activities of daily living and greater independence long-term. Looking more closely at the first option, regulating bowel and bladder elimination is important for maintaining dignity, hygiene, and comfort, but it is not as time-sensitive or permanently disabling as contractures. Bowel and bladder problems can often be improved with training schedules, timed voiding, and supportive regimens. Unlike musculoskeletal deformities, they do not permanently restrict rehabilitation potential, which makes this a lower priority goal. Turning to the third option, addressing altered body image is certainly vital for psychosocial recovery, as many clients experience frustration, loss of self-esteem, and visible physical changes after a stroke. Nurses should encourage independence, provide reassurance, and involve clients in care decisions to support self-image. However, even if body image is improved, mobility and independence will still be compromised if severe contractures occur. Therefore, this is an important but secondary focus during the early rehabilitation phase. Finally, considering the fourth option, fostering coping strategies for depression is also highly significant. Depression after a stroke affects nearly half of clients and can directly reduce participation in therapy. Nursing interventions may include supportive counseling, mental health referrals, and pharmacologic management. While depression can reduce progress, it does not directly cause irreversible physical limitation. Hence, although essential, it does not outweigh the immediate priority of preventing musculoskeletal complications. From a clinical perspective, stroke rehabilitation is grounded in the principle of function first. Without preserving mobility, all other goals lose effectiveness, because contractures, once developed, are very difficult to reverse. Nurses should prioritize positioning, consistent range of motion exercises, splinting, and early mobilization to preserve flexibility and prevent disability. And here is your Stancoast Pearl. Mobility is the gateway to independence. Early prevention of contractures is the nurse's most powerful intervention in stroke rehabilitation. Let us smoothly transition into this next NCLEX-style practice question that focuses on stroke rehabilitation and family education. A nurse is counseling the spouse of a client who experienced an ischemic stroke. The spouse reports that the client sometimes bursts into tears while eating or suddenly laughs during quiet conversation, even when the situation does not seem appropriate. The spouse asks, "Why is this happening?" Which is the best nursing response? Here are the options to consider. Option 1, your spouse may be trying to gain control over the situation through these mood swings. Option 2, emotional fluctuations, known as emotional lability, are common after a stroke and can cause inappropriate episodes of laughing or crying. Option 3, the stroke has completely destroyed the area of the brain that controls emotions. And Option 4, it is normal to become very emotional after a major life event such as a stroke. The correct answer is Option 2. Emotional fluctuations, known as emotional lability, are common after a stroke and can cause inappropriate episodes of laughing or crying. Now, let us carefully examine the rationale. This is correct because the phenomenon being described is post-stroke emotional lability, also referred to as pseudobulbar affect, PBA. It results from disrupted neurotransmitter pathways between the frontal cortex, brainstem, and cerebellum that regulate affective responses. The client may display sudden, involuntary episodes of crying or laughing that are out of proportion to the context. Crying is reported more frequently than laughter, and importantly, these behaviors are not under voluntary control. Both the client and family may feel embarrassed or distressed, so providing education helps normalize the experience and reduces frustration. Treatment may include reassurance, coping strategies, and sometimes pharmacologic management, with agents such as dextromethorphan combined with quinidine. Turning to Option 1, this is incorrect because suggesting the client is trying to gain control implies intentional manipulation. In reality, emotional lability is a neurological complication and not a conscious strategy. Framing it this way could increase caregiver frustration and create stigma. Considering Option 3, this is also incorrect. While stroke can damage pathways that regulate emotional expression, it rarely destroys the emotional center entirely. Instead, there is a disruption in neural communication, leading to inappropriate outbursts. The wording here is misleading and oversimplified. Finally, Option 4 is not the best choice, because although it is true that many individuals become emotional after life-changing events, what differentiates post-stroke lability is that the outbursts are neurologically driven rather than purely psychological. Unlike situational grief, these episodes appear abruptly, are disproportionate to the environment, and resolve quickly without linkage to actual mood. Here are some clinical pearls to strengthen your NCLEX preparation. First, remember that pseudobulbar affect is distinct from depression, though they may coexist. Second, education for family members is crucial to prevent misinterpretation of symptoms and to support coping. Third, recognizing this condition early can improve patient-family relationships and guide referral for treatment if symptoms are severe. And finally, an NCLEX strategy tip. Whenever the question asks for the best nurse response, choose the option that explains the physiological basis, avoids blame, and fosters family understanding. Now, let us move into an important NCLEX-style question on client and family education. A client with a history of ischemic stroke is being discharged home on a new prescription for warfarin, also known as Coumadin. The nurse is preparing discharge teaching for the client's spouse, who will be assisting with home care. The question asks, which of the following topics are essential to include in the teaching plan? The options are dietary restrictions, avoiding heavy lifting, staying out of bright sunlight, management of missed doses, recognition of bruising or blood in urine, and need for frequent laboratory monitoring. The correct answers are options 1, 4, 5, and 6. Let us break this down together. First, considering dietary restrictions, this is correct. Warfarin acts by inhibiting vitamin K-dependent clotting factors, and foods high in vitamin K such as spinach, kale, broccoli, or Brussels sprouts can reduce its effectiveness. However, the teaching point is not total avoidance, but consistency. Clients must keep their vitamin K intake steady so that INR levels remain therapeutic, and clot prevention is effective. Next, when we look at avoiding heavy lifting, this is not required. While warfarin does increase the risk of bleeding, there is no specific prohibition against lifting unless other conditions exist, such as post-surgical recovery. Instead, the priority is injury prevention. Patients should use an electric razor, a soft toothbrush, avoid contact sports, and focus on fall safety, which directly reduces bleeding risk. Moving on to sunlight exposure, staying out of bright sunlight is also unnecessary. Warfarin is not known to cause photosensitivity, unlike certain antibiotics or diuretics. Teaching patients to avoid sunlight could overwhelm them with irrelevant instructions and distract from life-saving safety precautions. Shifting to the fourth point, the management of missed doses is absolutely essential. Clients must be taught never to double up on their warfarin. If a dose is missed and remembered the same day, it can be taken. But if it is not remembered until the next day, it should be skipped and the regular schedule resumed. In all cases, the healthcare provider should be notified for safe guidance. This rule prevents both clot formation and dangerous bleeding. Now, addressing recognition of bruising or blood in urine, this is another critical teaching point. Because warfarin thins the blood, patients must be vigilant for warning signs such as unusual bruising, hematuria, tarry stools, nosebleeds, gum bleeding, or prolonged bleeding from minor cuts. Early recognition of these symptoms can prevent life-threatening hemorrhagic events and ensures immediate medical evaluation. Finally, we come to the need for frequent laboratory monitoring, which is also correct. Warfarin therapy requires close regulation using prothrombin time and the International Normalized Ratio, or INR. For stroke prevention, the target is generally between 2.0 and 3.0, while clients with mechanical heart valves may require higher therapeutic ranges. Testing is frequent at first, every few days, and then becomes regular once levels stabilize. In addition, clients must know that many over-the-counter medications, antibiotics, non-steroidal anti-inflammatory drugs, and herbal supplements like garlic or ginkgo can dangerously interact with warfarin, making communication with providers absolutely essential. To bring everything together, here is the Stan Coast Pearl. Safe warfarin use relies on 4 keys: diet, dose, danger signs, and diagnostics. Diet means consistent vitamin K intake. Dose means never doubling a missed dose. Danger signs means always watching for bleeding. And diagnostics means keeping up with Indian rupee checks. Remembering these 4 keys ensures both client safety and successful stroke prevention. Let us smoothly move forward into another essential NCLEX-style question that highlights both pathophysiology and safe nursing practice. A nurse is developing a care plan for a client who has recently experienced an ischemic stroke. During assessment, the nurse identifies homonymous hemianopia, which is a visual field defect leading to blindness in the same half of the visual field in both eyes. The question asks, which intervention should the nurse prioritize to enhance the client's safety and functional independence? Here are the options to consider. Option 1, have the client wear dark glasses when in bright light. Option 2, cover the client's affected eye with an eye patch. Option 3, approach the client from the unaffected side. Option 4, position food on the tray resembling the face of a clock. The correct answer is option 3, approach the client from the unaffected side. Now let us break this down with deeper reasoning. Hemianopia occurs when a stroke damages the optic pathways in the brain, often involving the occipital lobe or optic tract. This condition results in loss of vision in one half of the field, either left or right, depending on the site of injury. Because vision loss is symmetric in both eyes, the client may not notice people, objects, or food placed on the affected side, which dramatically increases fall risk and interferes with daily living activities. Focusing on the correct option, approaching the client from the unaffected side is the safest and most therapeutic action. This strategy allows the client to maximize residual vision, decreases startle responses, and promotes orientation and communication. It also builds client trust and reduces anxiety. Beyond immediate safety, it helps train compensatory behaviors such as scanning techniques, where the client consciously turns their head toward the blind field to reduce neglect and improve functional independence. Turning to the incorrect choices, wearing dark glasses in bright light may help in conditions like cataracts or corneal abrasions. But in hemianopia, light sensitivity is not the issue. Therefore, this intervention has no effect on safety or vision function. Covering the affected eye with an eye patch may be useful in double vision caused by extraocular muscle imbalance. But since both eyes share the same deficit in hemianopia, patching only reduces binocular vision and depth perception, increasing the risk of injury. Lastly, positioning food like the face of a clock is appropriate for clients who are fully blind, as it offers a tactile orientation system. However, in hemianopia, half of the visual field is absent, so the client would still miss part of the tray regardless of a clock method. Instead, placing items on the intact side or teaching scanning is more effective. Here is the clinical insight you should carry with you. Maximize what is left, compensate for what is lost. In hemianopia, always approach from the intact side, organize personal items on that side, and reinforce scanning strategies. This approach preserves safety, supports independence, and prevents frustration. Unlike complete blindness, hemianopia requires retraining visual attention rather than relying solely on tactile orientation. Let us now dive into another advanced NCLEX-style scenario that challenges critical prioritization skills. A client with a leaking cerebral aneurysm is being managed conservatively with strict bed rest, anticonvulsants, and sedatives. The nurse's responsibility is to monitor for subtle yet dangerous changes that could precipitate aneurysmal rupture. The question posed is, which observation requires the highest priority nursing intervention? Here are the options to evaluate carefully. Option 1, the client has a chronic cough. Option 2, the client is becoming jittery. Option 3, the client's skin is warm and clammy. Option 4, the client develops diarrhea. The correct answer is Option 1, the client has a chronic cough. Now let us carefully examine the reasoning behind this choice. A leaking cerebral aneurysm involves a fragile, weakened arterial wall within the brain that is highly prone to rupture. Any activity that sharply raises intracranial pressure, such as coughing, sneezing, or straining, can forcefully increase pressure on the aneurysm and trigger catastrophic hemorrhage. Once rupture occurs, the outcome is often fatal, with mortality rates exceeding 50% even with rapid medical intervention. Therefore, the absolute priority in care is prevention of intracranial pressure spikes, and addressing coughing is paramount. Looking more closely at Option 1, chronic coughing is extremely dangerous in this client because each cough abruptly increases intrathoracic pressure, impedes venous return, and produces a surge in intracranial pressure. This can rupture the aneurysm wall almost instantly. Nursing interventions would include administering prescribed antitussives, maintaining humidified air, and ensuring the client avoids activities that could trigger coughing. This makes it the most life-threatening observation and the highest priority. Switching to Option 2, jitteriness signals agitation, anxiety, or possible neurologic irritation. While concerning, it does not directly increase intracranial pressure in the same way coughing does. It should still be addressed with sedation, reassurance, and reduced stimulation, but it is not the immediate threat compared with violent coughing. Considering Option 3, warm and clammy skin may indicate infection, hypoglycemia, or sympathetic stimulation. These are significant clinical findings, but they do not directly rupture the aneurysm. The nurse would need to check vital signs, assess glucose, and evaluate for systemic infection. But again, coughing remains the highest risk factor. Finally, Option 4, diarrhea, can result in fluid and electrolyte imbalance. Although straining during bowel movements can increase intracranial pressure, diarrhea itself does not cause repeated and forceful pressure surges like coughing does. Nursing interventions such as hydration and electrolyte replacement are necessary, but this does not take precedence over controlling cough. To bring all of this together, the clinical pearl is clear. In clients with cerebral aneurysms, prevention of rupture is the central nursing goal. This means avoiding all activities that increase intracranial pressure, including coughing, sneezing, vomiting, and straining. Essential nursing measures include administering stool softeners, antitussives, and antiemetics, maintaining strict bed rest, providing sedation, and ensuring a quiet, stress-free environment. Stancoast. Pearl. In aneurysm care, pressure is the enemy. Prevent every possible spike in intracranial pressure to protect life. As we move forward into another challenging NCLEX prioritization scenario, let us carefully analyze this next question. A nurse is preparing to examine a client admitted with a conservatively managed cerebral aneurysm. The nurse must perform a comprehensive assessment but prioritize in a sequence that reflects safety, neurologic deterioration, and risk reduction. The task is to place the following assessment areas in order of priority, with the most critical assessment listed first. Here are the options: bowel elimination, motor strength, vital signs, skin integrity, urine output, and level of consciousness. Now let us reveal the correct sequence of priorities. First comes level of consciousness, followed by motor strength, then vital signs. Next, urine output, then bowel elimination, and finally, skin integrity. Let us now explore the reasoning step by step. The very first and most critical assessment is level of consciousness, because even subtle changes are the earliest and most sensitive indicators of cerebral perfusion, problems, and neurologic deterioration. In a client with a cerebral aneurysm, confusion, restlessness, or inability to follow commands may indicate increasing intracranial pressure or bleeding, which can quickly progress to coma. This is why level of consciousness always takes precedence. Moving on to the second priority, motor strength must be checked to determine if the client can follow purposeful commands and to detect any asymmetry or drift, which may indicate evolving ischemia or compression. Detecting these early prevents long-term neurologic deficits. The third step is to evaluate vital signs, which are important but usually change later in the course of deterioration. Alterations such as bradycardia, hypertension, and irregular respirations signal late intracranial pressure changes, known as Cushing's triad. So they are monitored closely, but follow after neurological checks. Shifting attention to the fourth priority, urine output becomes essential because it indirectly reflects systemic perfusion and fluid balance. Decreased output may point to hypoperfusion, renal compromise, or medication effects. Next, bowel elimination is addressed, as straining during defecation can dangerously increase intracranial pressure and risk of rupture. But it is less urgent than neurologic or hemodynamic findings. Finally, skin integrity is assessed last, since the risks of pressure injuries from strict bed rest develop gradually and do not pose immediate life-threatening danger, though preventive care must still be implemented. Before we conclude, let us highlight some high-yield pearls for NCLEX success. Always remember, that level of consciousness is the earliest and most reliable indicator of cerebral perfusion. Motor changes often occur before vital sign instability. Recognize Cushing's triad as a late and ominous sign of rising intracranial pressure. Prevent straining during bowel movements through stool softeners to avoid sudden increases in pressure. And although skincare is vital for long-term recovery, neurologic assessments always take precedence. Now let us turn our attention to a complex NCLEX scenario involving neurologic safety. A client with a conservatively managed cerebral aneurysm reports that the non-opioid analgesic administered 2 hours ago has not provided enough relief for a persistent headache. The prescription states that the analgesic can be given every 3 to 4 hours as needed. Considering the risks associated with pain management in neurologic conditions, the nurse must carefully choose the most appropriate intervention. Here are the options to consider. Option 1. Administer another dose of the non-opioid analgesic immediately. Option 2. Adjust the medication schedule so the client receives analgesia every hour. Option 3. Request an opioid analgesic order from the healthcare provider. Or Option 4. Implement a complementary non-pharmacologic pain relief measure, such as guided imagery or relaxation techniques, in conjunction with current pharmacologic therapy. The correct answer is Option 4. Implement a complementary non-pharmacologic pain relief measure, such as guided imagery or relaxation techniques, in conjunction with current pharmacologic therapy. This choice is correct because clients with cerebral aneurysms are at risk for increased intracranial pressure and rupture, making safety the highest priority. Non-opioid analgesics are prescribed every 3 to 4 hours for a reason. Dosing too soon increases the chance of drug toxicity, especially with acetaminophen or NSAIDs. Opioids are avoided because they can cloud neurologic assessments by altering pupil reactivity, level of consciousness, and respiratory drive, all of which are essential for early detection of deterioration. Therefore, the safest and most effective intervention at this moment is to enhance pain relief by combining the prescribed medication regimen with non-drug strategies such as relaxation techniques, guided imagery, distraction, or cool compresses, which help reduce discomfort and anxiety without jeopardizing neurologic monitoring. Looking at the incorrect choices, option 1, administering another dose immediately, is unsafe because it breaks the minimum dosing interval rule, risking hepatotoxicity and other adverse effects. Option 2, adjusting the schedule for hourly dosing, is inappropriate as nurses cannot independently alter prescribed intervals, and hourly dosing would dramatically raise the risk of accumulation and organ toxicity. Option 3, requesting an opioid analgesic, is generally contraindicated in clients with cerebral aneurysm since opioids can suppress respirations, cause constipation leading to straining, and most critically, mask neurologic warning signs of bleeding or rupture. Here is a high-yield Stan Coast pearl to remember. Neurologic safety always comes first. When managing pain in clients with cerebral aneurysm, avoid opioids, respect minimum dosing intervals, and combine pharmacologic therapy with safe non-pharmacologic interventions to optimize comfort while ensuring accurate neurologic monitoring. Thank you. We will see you next video.